Hello everybody and welcome to week 5. In this week we are primarily going to be exploring what we would commonly talk about the phases and stages of labour, or sort of I suppose more typically how a normal physiological labour would flow. So we'll sort of break that down. We'll also spend a little bit of time looking at the doula's role through that perinatal period, and so that precedes labour. A little bit of an intro into sort of the antenatal period and sort of the role that you play in those antenatal appointments, particularly, although that will be more sort of content that we cover in week 6. But a little bit of an overview of that. But what we'll focus on a little bit more in this week is, I guess, the doula's role as far as, the importance of building a relationship of trust with your client, establishing those clear goals and expectations as well, right from the outset, what you do, what you don't do, and really understanding as well your client's needs and their expectations of your support. One of the things we'll just finish up with is it's sort of not specifically linked to discussions around phases and stages of labour and so forth, but I just wanted to pop it in here, and it's a very quick video which you guys can watch about something called the Cochrane database. For those of you who have perhaps a little bit of a background, in academia, or you're at uni currently, or have been, in recent years, you might have come across something called the Cochrane database. So I'll leave that video there for you to watch. The reason I've popped that in there is because inevitably, as you support clients, things will crop up. Again, particularly in those antenatal appointments where perhaps a client has sort of said to you, oh, the midwife said this to me in the appointment, or, the doctor said that I'm going to need an induction because my baby is big, or because I'm of South Asian background, and, all of these sort of things where, your role as a doula is not necessarily to be that of a childbirth educator. They are two very different professions, but there is crossover. And so one of the things we want to ensure as doulas is that if we are passing information on to clients, we know that it's come from a really, really good source. We know that it's evidence-based, we know that it's current, we know that it's free of bias, for example. So what I'm not suggesting is that you download, complex research papers from the Cochrane database, but it's really more for you to be able to look things up, know where to look, and why the information that is in Cochrane is so good and so reliable. We'll talk later in the course about where you, do source really good sources of quality information, both for yourself as doulas, but also information that you could pass on to clients that is a little bit more accessible. It's written with parents or consumers in mind, therefore it's a lot more easily understood, and it's a bit more digestible and relevant for families, rather than that sort of really high level academia. But I just thought I'd just give you a little bit of insight into really what we consider to be the gold standard of evidence-based research and where to find that. It is a little bit limited in terms of what you can access. You do need what's called institutional access to really be able to dig into everything that exists within the Cochrane database. But certainly I think for our needs as doulas, you don't necessarily need to dig down to that level. What anybody can access in Cochrane is what we call the abstract of a study, and that's basically like the summary, the key takeaways, what the study was, what they were wanting to research, and what the high level findings were. And they often in Cochrane, which is a really great thing, is they put the plain language summary. So it's kind of like, the bottom line for everyday person, as I said, not the academic. What did this study find? So you can get really good information for clients, and even if it's just pulling, as I said, that plain language summary, that might be really helpful in giving them information that you know is really good quality, that then they can use to have further discussions with their care provider, for example. So that's kind of a quick summary of what we're going to cover in this week. Okay, so before we sort of get into the sort of phases and stages of labour, I think it's important just to have a little bit of basic understanding of anatomy and physiology of pregnancy, and particularly understanding what happens during those 3 trimesters. And so one of the little homework assignments for this week is to read, you can have a look here, sorry, this is the Preparing for Birth booklet, which hopefully you've all got a copy of. I know that some people were still waiting for their copy to arrive in the mail, but I'm sure you'll get that really soon. So you'll see in Better Impact exactly what to read, but it's basically pages 2 through 15. And that will give you a really, as I said, very basic but good and comprehensive overview of the anatomy of pregnancy and birth, an understanding of the different trimesters, and as well as things like the first, second and third stages of labor, which we're about to get stuck into. So just pop that up there just to remind you just to maybe have a read of the booklet first before, and maybe just pause the video here, have a read of that, and then join back and watch for the next few slides. So another thing I just wanted to also highlight a bit, and this is just carrying on from some of what you would have watched in last week's videos. That really is a really good video on the hormones of pregnancy, birth, and early postpartum. So I just wanted to touch back on that, because really when we are talking about how labour typically unfolds, it's pretty much impossible to talk about labour without talking about the hormones. And I certainly make it a point with clients, and both with doula clients and when I'm teaching childbirth education classes, to really highlight the importance of hormones, what they are, what they do, also very importantly, what happens to hormonal release when it's interrupted. And that interruption can be in the form of a synthetic form of that hormone. For example, oxytocin is a very good example. Oxytocin obviously is released by the brain, but we have a very commonly used labor drug called syntocinon, and that is a synthetic form of oxytocin. So what happens when the mother's body is receiving syntocinon via IV drip? What happens then to the natural flow of oxytocin? So that's one way that natural hormonal release can be disrupted. Another one is the use of pain medications. So for example, if a client opts to use and have an epidural, what happens to things like endorphin release, for example, or what happens to adrenaline or the catecholamines, the stress hormones, when a person has pain relief on board. So that's another way that natural hormonal release can be interrupted. And of course, it's important to remember that emotions and your emotional state play a huge role as well on how hormones flow, essentially, and also the balance, say oxytocin versus the stress hormones. So all of that would have you watched in that video last week, but I just thought it's important just to sort of bring us back to that again. So just to highlight here on the slide is that we've got oxytocin, a really, really crucial hormone which really drives labor. It is called the hormone of love. It causes those contractions, and for the uterus to contract efficiently, and increasingly for those contractions to be stronger and closer together. But very, very importantly, the only way that a person's body can produce and release high amounts of oxytocin, and certainly the amounts required for labor to progress well, is when that person is feeling safe and supported and private, and in an environment where they do feel really cared for. And so the environment plays such an important role in labor. And of course, when we think about typical sort of hospital birth suites, they're not really places of privacy and calmness, you know, and so it's really easy to understand why so frequently we see labor slowing down or even kind of coming to a bit of a grinding halt in the hospital, because women do know and do instinctively feel that they're not in their sort of safe zone anymore. So oxytocin's a really big one. Endorphins, often unknown as nature's sort of natural painkiller or nature's opiate, and are extraordinary hormones because, you know, they are released at a point in labor when the woman's body is working really, really hard, often when she has moved into sort of active labor, and essentially these hormones are released to really help her to manage the intensity of labor. And I think one of the things that, you know, we'll talk about pain and the role of pain in a future session, but I think one of the things I find personally most fascinating about endorphins and their role, you know, in labor, and also very specifically when they're released in labor, which is, as I said, this really intense part of labor. Endorphins are not really released, certainly not in any sort of significant amount, in early labor, you know, when contractions are spaced apart and they're mild, they're not particularly bothering, you know, mum, and there's a reason for that, because when labor does become more intense and more difficult to manage, you know, that's the point certainly at which, you know, we do need something to help us to cope, and that's when the endorphins come to the rescue. But what's really interesting is that the body recognizes that, yes, it's certainly working really hard and that labor is intense and it's hard work, but the body also recognizes that you're not in distress, that they're not in danger in any way. And because of that, it will release the beta endorphins to help you to cope with that intensity. You know, for example, if you know, in contrast, a person you know, has a physical injury, you know, they break a bone, you know, an arm, a leg, twist an ankle, those sort of things, or are burned, you know, have a burn from you know, a hot water bottle, for example. Obviously, the body starts to release very high levels of the catecholamines, the stress hormones, and you know, you could argue, oh well, you know, they're both pain, right? Pain of labor, pain caused by injury, but the body is much smarter than that, and the body recognizes that in labor, yes, it's painful, if you want to use that word pain, but you're not in danger. Everything that's happening in the body is normal. Therefore, we're going to reward you by giving you these wonderful endorphins to help you to cope. However, if you're experiencing pain caused by injury, that's a pathological pain. That's not a normal pain. There is something wrong in the body, and the adrenaline is released to help you to pay attention to that and to be alert to that and to do something about it. And so therefore, your body is not releasing endorphins to help you to cope with that. That's where we actually do need, in some cases, the assistance of medical pain relief, such as morphine and, you know, whatever else may be appropriate depending on the injury. So that's just something I wanted to point out there that I certainly share with clients. I think it really helps them to excuse me, to reframe the concept of pain and labor, that if your body knows that you're not in danger, surely that does help you to understand that, yes, it's intense, but that nothing bad is happening to your body. And then just finally here, we've got prolactin. And even though when we talk about prolactin, we are primarily talking about the hormone that's responsible for breast milk production, which is very true. So it does get called sometimes the mothering hormone, but it is important to recognize that it is a hormone that exists in both men and women's bodies, and therefore it is also very commonly referred to as the parenting hormone. And that's because, and again, you might have remembered in that video, I think Sarah Buckley was talking about prolactin, and, you know, in the animal world where we see, you know, penguins who balance, you know, the little chick egg on their feet, and there are other animals in the wild as well that are really sort of charged with protecting the egg or the unborn baby and so forth. And so we see in humans when fathers are very actively involved in caring for their babies, and with lots of skin to skin, lots of hugging and holding and carrying, and massaging and playing and all those sort of things, those men have much higher levels of prolactin in their bodies than men who are more distanced and perhaps not as actively involved in the caring and looking after of their children. So that's just an interesting, again, sort of thing just to be to bear in mind, that prolactin is not a hormone exclusively in the bodies of just the birthing person. And I should say that is true for all these hormones. Obviously, men and women have oxytocin, we both have endorphins, we both have the stress hormones, the catecholamines, and prolactin. So I think that's important just to bear that in mind, that obviously the person who is in labor has a whole different experience, hormonally in every other way, but that also, fathers are present at the birth, that they are also experiencing a not dissimilar flow of hormones. If the mother is really calm and really, coping really well with the labor, we're less likely to see stressed and anxious partners. However, it can be the opposite. A very stressed and anxious, dad in the room can also cause his partner to then experience a lot of stress and anxiety as well. It is, again, from a doula's perspective, we bring it back to the doula, creating and helping to keep an atmosphere of calm and quiet and in a relaxed space where people feel really protected and really safe is such an important thing that we do, because it just has such a, important knock-on effect on the whole flow of labor. So I'm, as you can probably tell, I'm a little bit passionate about hormones, but I think it's so important that we do share this information with clients. It really helps them to understand what's going on in their bodies, and that, there is a rhyme and reason to, what's happening to them at different stages. And also it really helps to explain those phases and stages of labor more easily. I'm just going to explain very quickly here about something that some of you might have come across before, and perhaps if you haven't actually heard of the theory, you might actually just be familiar with, the actual cycle itself. So as you can see on this slide here, we're talking about something called the fear, tension, pain cycle. Now, this was, I guess, a theory, if you like, that was, described by an English obstetrician called Dr. Grantley Dick Reed back in the 1940s, very long time ago, I know. He is well known in the birth world, and wrote a number of books. But the one where he actually described this theory of the fear, tension, pain cycle was in a book called Childbirth Without Fear, which was published in 1944. You can actually still buy it and still read it. It actually had a bit of a revival recently and was republished in the last few years. So, if you're a bit of a birth nerd and you want to sort of start building a little bit of a library, you could certainly get a hold of it. And I wouldn't be surprised if, you could get it in your library, your local library, or ask them to bring it in. That's another great thing about council libraries, is you can put requests in and they can get books in for you. So basically the sort of quick explanation of fear, tension, pain, and again, it's pretty self-explanatory. If we start with fear, if fear is the dominant emotion that a person is experiencing right from the outset of labor, even in the lead up to labor, if a person is carrying a lot of fear about what labor might be like and how they're going to cope, will they cope with the pain and all of those sort of things. So fear is really dominating them, as I said, from an emotional perspective. And when you enter and start a process of labor with fear, essentially that's going to cause a physical response in the body, which is one of tension. When we're fearful, we hold tension in our body. Sometimes we're not even aware of how much tension we do carry in our body. One of the things that we'll do probably in that active labor session where we're all meeting in person is we'll do a progressive relaxation exercise, a sort of a meditation where, and again, some of you might be really familiar with this concept, where you tense and relax individual muscle groups as you progressively go through your body from the sort of top of your head down to the soles of your feet, because many of us carry tension in our body without even recognizing that that's what we're doing. But certainly when somebody is really fearful, there's a lot of tension in the body. And when there's tension, the physical knock-on effect of that is that we have very tense and hard muscles. And when muscles are hard, they have very poor oxygen flow through those muscles. And, you know, when there is poor oxygen flow in the mother, obviously, eventually that will have an impact on the baby as well. And, you know, if a woman is feeling sufficiently fearful, frightened, and is holding lots of tension in her body, first of all, labor will be slow. Labor will slow down. The oxytocin levels will probably plummet. The adrenaline, that fight or flight hormone will start to increase. As I said, the muscles are tight. They have poor oxygen flow through them. And remember, the uterus is a muscle. The cervix is a muscle. And so if they're both really, really tight and holding lots of tension, the uterus can't contract efficiently. The cervix can't stretch and thin and open up effectively, and so we see labor really starting to slow down, and in some cases can really even come, as I said, to a complete sort of grinding halt. And so the sort of the knock-on effect of the tension in the body is a lot more physical pain. You know, when you tense your muscles for a long period of time, you will feel pain more intensely than if your muscles are really, really relaxed. I'll give you a bit of a morbid example of that. So if you think about really serious car injuries, you know, experts will always tell you that adults are impacted physically far greater than children and infants. And that's because as adults, we tend to carry a lot more tension in our bodies at all times. And when we have an awareness that we're about to have an impact, an accident, we tense, we brace for that impact. Children don't do that. They're kind of floppy naturally, and their muscles are relaxed. And as a result, they tend to have far less of a physical impact and injuries than adults do. So taking that back to a sort of a birth context, when the muscles are tight and hard, you feel pain more intensely. And of course, what happens when there's more pain? There's more fear. And so you can see very quickly how this becomes a cycle that can be very, very hard to break. And certainly when that fear is not addressed from the outset, and a woman sort of, you know, finds herself, as I said, in this sort of, you know, almost self-fulfilling prophecy, it can be a situation where that person goes from, you know, experiencing physical pain to really moving into sort of a space of suffering. And that's something, again, we'll talk about more in the session where we really kind of unpack the role of pain and labor. But the important thing is that if we can recognize as doulas that our clients have moved from that, you know, normal pain, dealing with, coping well with pain and being on top of it and recognizing that, you know, it's normal, to really emotionally suffering, that's something we need to address as doulas, and that's something we want to make sure that our clients don't experience, because that absolutely can lead to birth trauma. And that's something we want to avoid, and really to help support and protect our clients from experiencing as much as we possibly can. So it's just an interesting thing for you to have a think about. You know, certainly if you want to, you know, delve into it a little bit more deeply, just absolutely, I'm sure if you Googled fear, tension, pain cycle, or you wanted to read up a bit more about Dr. Dick Reed, there's lots of information out there, but I just thought I would give you a little bit of a sort of bit of backstory to that. Again, really helps you to sort of understand, I guess, the psychology behind what people are experiencing during labor. So before we get really sort of into discussing the various phases and stages of labor, again, I want to sort of take you back a little bit and just sort of think about what are the sort of normal physiological as well as some of those emotional signs that labor might be imminent. And that's because you may very well get questions or calls or texts from your clients who are noticing that things are happening and want to know, does this mean I'm going to go into labor, or has labor started, or is this a sign of labor, and so forth. So it is really helpful for you to know what these sort of very common early indicators are that labor could start certainly in the next days or within the next week or so. So this is a little homework assignment, and you'll see in Better Impact that I'd like you first to read a little article that is in the student workbook. And it's a little piece called The Simple Story of Birth, which you'll see on pages 21 and 22. But you'll have all those instructions in Better Impact for you. And basically all you need to do, as you can see from this slide, is to kind of rearrange this list into sort of more of a logical order. It's not an exact science. It's not, there isn't a 100% right or wrong on any of this. But once you've read that Simple Story of Birth, it'll give you probably a better idea of, what's likely to kind of be the earliest indicator that labor could be sort of around the corner or, imminent in some way, versus some of the later and more obvious signs that clearly labor has started, or it was really in that early stage of labor. So you're welcome to pause the video now and go off and do that, or just do that a little bit later after you've watched all of the recording from this presentation. Right, so let's get started talking about how labor, as I said, typically unfolds. And I'm obviously talking about a spontaneous labor as opposed to something like an induction of labor where labor is started artificially. So what we're effectively talking about is normal physiological labor. Again, some of you might be quite familiar with this information, and for others it might be a lot newer. So obviously feel free to sort of, skip ahead a little bit if this is information that you're very familiar with. One thing that I would actually really like you to do, even before you listen to me rambling for the next few slides talking about these different stages of labor, is another little homework exercise. Again, you'll see this in Better Impact and the link to it. There is a podcast which I really highly recommend to anybody who's interested in birth, and that includes clients. It's a podcast called The Midwives Cauldron. It is hosted by two midwives, and the main one, if you like, and the person that many people are quite familiar with, is Dr. Rachel Reed, who's a professor of midwifery, who originally from the UK, but she's based up on the Gold Coast, and she and the name always escapes me of the other midwife who co-hosts with her. But I have linked to a very specific episode in their podcast, which really talks about how we should perhaps start to, really talk about how labor unfolds. And Rachel kind of proposes, what might seem a little radical, but to try and move away from this concept of stages and phases, which, to be honest, if we think about it, are very much, man-made terms. It's a way of sort of, I guess, compartmentalizing and separating out different sections of labor. But definitely, if you've got some time, even just hit the pause button on me right now, go off and have a listen to this fantastic podcast from the Midwives Cauldron. I highly recommend you subscribe because it's very, very addictive. The two of them are just brilliant co-hosts. They interview the most fantastic guests. They've had Dr. Sarah Wickham, they've had Sarah Buckley, they've had, just trying to think who else they've had, Hannah Darlin, all sorts of amazing, brilliant minds on this show. I'm continually learning. It's one of my favorite kind of road trip podcasts to stick on. Often when I'm on my way to a birth or on my way to a sort of an antenatal or a postnatal visit. So have a listen to that, because I think it'll kind of get you to think about things in a really different perspective before we even kind of get go through things in a sort of more accepted and familiar way when we're describing labor and birth. So that aside, that is exactly what I'm going to do now. And the reason I will describe labor in these terms is largely because that's exactly the language that our clients are hearing. It's the way that labor is described in all the books. It's the way labor is described by their care providers. It's what midwives will tell them. It's what doctors will say. It's as I said, in the books, it's online. So it's really, really hard to escape this. So we do want people to understand it. It certainly has its benefits in terms of helping people to understand, the flow of labor. So I think it is important that we do have, some understanding of this as well. So when we are talking about labor, essentially, labor is divided, if you like, into 3 distinct stages. And within stage 1, there are 3 phases, so sort of subsections, if you like, of stage 1. Stage 1, which I said encompasses phases 1, 2, and 3, is without doubt the longest part of labor. It has essentially 2 significant components to it. The first is the start of contractions that eventually become longer, closer, stronger, etc. So it's the increasing kind of contractility of the uterus. And then the other really important part is the thinning and opening of the cervix. Until such point that the cervix essentially has really kind of disappeared, there's no cervix left, and that allows for sufficient opening for the baby to be born vaginally. So they're really the 2 main important aspects of the whole first stage of labor, is those increasing contractions and the increased dilation and effacement, or the thinning of the cervix. And of course, we can't forget the baby as well. The other really important aspect of the whole first stage of labor is the descent of the baby, and also the baby starting to rotate in the pelvis and finding the best fit for them at each stage as they descend through the pelvis as well. So mum and baby are working very closely together. If I backtrack to the first phase, as you can see on this slide, it's really important to just be mindful of the fact that if you have a client who's having their first baby, it's very normal for this very early part of labor to last for up to a few days. That does not mean that she's in labor for 3 days. It means she's in an incredibly early part or a latent phase of or prodromal labor. There's lots of sort of different terms that we can use. But effectively, what it means is that your body's not quite ready for this whole process to really kick off. So what often happens in these early phases is that the mum will experience more contractions, more often late in the day, through the evening they kind of build up a little bit. You kind of get really excited and you think, yep, this is it, labor is happening, and then she gets really, really tired, she gets into bed, she falls asleep, wakes up the next morning, no labor, no baby. And that's a very, very common, pattern to occur. It's like the body's like gearing itself up and it's like getting ready, but no, I'm not quite ready just yet. So things sort of start to sort of slow down or fizzle out. And that's a good thing, for the body to really ease into this process is a good thing. And it really means that, that woman's body knows exactly what it's doing, that baby knows what it's doing. So we want to warn people to let them know that this is normal. This is a good thing. This is something we expect to see with a first baby particularly. If you have clients who are having their second, third, fourth baby, for example, this is not so much of something that we tend to see with people who have had other babies previously. We call them multips. They've had multiple babies before. That they tend to move from kind of no labor into active labor much more efficiently. So if you do have a client who's not a first-time mum to be mindful of that from a doula's perspective. She might not need you in 3 days. She might need you in 4 or 5 hours. Okay, so there's a little bit of a different expectation there. In terms of the early contractions in this first phase of labor, very normal for those contractions to be mild, not particularly bothering her. They will become a little bit, more intense as time goes on, but certainly in the earlier parts of labor, it's not unusual for them to be 20, even 30 minutes apart. They don't last very long, maybe 30 to 45 seconds each one. And then, as I said, a long gap until the next one. So, in terms of practical terms, that mum is kind of more or less carrying on normal activity. She can walk through and talk through contractions. And they're not sort of really bothering her all that much. And the best bit of advice I think that we can share with clients is that during this early phase of labor, if she can get more sleep, that is the absolute thing she should prioritize is sleep. And if not actual sleep, then as much rest as she can get. Really get into bed, stay hydrated, snack as she wants to and needs to lightly through the day, keeping her energy levels up. The hydration is very important. She urinates, goes to the toilet pretty regularly, but that sleep and just really, really just dialing it down. That's what we really want her to focus on. Because she's going to need that energy for later. And I think a very common mistake, a rookie mistake that a lot of first-time mums make is they get super excited because this is it, labor is starting. So they think, right, I've got to start, doing some walks around the park or climbing the stairs up and down and anything to get labor going. But they literally run out of steam before they've even, they've left the starting gates. And maternal exhaustion is a real thing and it's a real issue of concern. With a first baby, labor could be, from this point to birth, really could be, as I said, a few days, but even when labor really starts and it properly and establishes, a proper and consistent flow of contractions, she could still be in labor for, 24, 36 hours. And so there's no way that you can do that and sustain that kind of physical intensity if you're not well rested. Okay, so that's the main message I would be sharing with clients is rest, rest, and more rest in the early phase of labor. Just finally here, the last dot point there about the cervix. I think one of the things we actually do want to do is to encourage clients not to be super fixated on cervical dilation. It's one of those things, unfortunately, that's become so much a part of the way we talk about labor is the how many centimeters, you are. And it's one aspect of labor progress, but it's only one aspect of labor progress. There are so many other things happening both in the woman's body and things that the baby is also doing to help to progress labor that we really need to move away from this fixation on the how many centimeters. The only point I would make about cervical dilation in this context is that a few years ago, probably I would say about 7 to 8 years ago, there was a shift in what was considered to be active labor for forever and a day, active labor was considered to start around 3 centimeters of dilation, provided that that woman was experiencing regular contractions as well. What we know now, again, from a great deal of evidence, and this has really shifted, what healthcare providers are now really determining to be active labor, is from about 6 centimeters of dilation onwards. So really anything prior to 6 centimeters should not be considered active labor. It should still be considered early labor. This slide here, phase 1 of early labor. And that's a good thing for women, because the longer that her care provider kind of puts off actually labeling and sort of officially, noting or charting in her file that she's in active labor, the less clock watching, the less pressure she's under for things to progress at, however many centimeters per hour, or whatever the sort of outdated measurement of labor progress, we often sadly still see in the hospital setting. So, and obviously the way to avoid knowing how many centimeters you are is don't have any vaginal examinations. So, look, hospitals are, and not all, but some hospitals are certainly getting better. And midwives are really aware of this and recognize that the longer they put off that initial VE, or vaginal examination, the better, because the clock doesn't start ticking until that happens, and they actually put into the system active labor began at X o'clock. So I do put that in there really for here, because I want our clients to understand that it's a good thing that this has shifted further along. It means there's less intervention, or she's less likely to experience intervention too early in her labor, or this should be the case. It doesn't mean, however, that she's not in labor. And I think we want to make that sort of differentiation between a clinical, kind of, if you like, diagnosis, which is a terrible word, but it's kind of what they use, a clinical diagnosis or definition of labor, versus what is she actually feeling and experiencing. And the truth is, if you've got to 4 centimeters, you're going to be feeling really intense contractions. That's, some of them are going to take your breath away a little bit. So we don't want to tell that woman, oh, you're not in labor yet, this is not labor, because she's likely to go, oh my goodness, if this is not labor, what's coming, right? So we don't want to put that kind of fear into her. We want to let her know, you're doing amazing. This is brilliant. Your body is working so beautifully. Your baby is so smart. And this is exactly what needs to happen. But this is great, because you know what? We can stay at home longer. You can put off intervention, because this is really still the earlier part of labor. And we're just going to let your body do exactly what it needs to do. So that's the kind of message we want to share with women. And again, ultimately we want to move away from this obsession with the how many centimeters. So that's early labor, phase 1. I hope that has sort of given you a little bit of an overview of what's likely to happen at this stage of labor. So now we're moving on to phase 2. We're still in stage 1 of labor. Remember, we've got 3 phases to progress through. But phase 2 is often referred to as active labor. And as you might recall, our next in-person session is kind of an active labor workshop. So that is a session where we're going to focus on comfort measures, relaxation techniques, all the sort of really hands-on doula skills, things that you can do to really support your client through this part of labor, which is when things really start to kind of get a little bit more intense. You can see here from the slide, active labor again varies. The length of time persons in active labor varies considerably from person to person. But, I would say, again, with the first baby, typically we're talking 8 hours more, 8 to 12 is very, very normal. The contractions themselves really start to intensify. And they get more close together as well. So rather than that sort of 7, 8, 10 minutes apart, like we saw in the first phase, in that early phase of labor, Contractions should now be pretty consistent. So we're looking at somewhere between sort of 3 and 5 minutes apart. They're also lasting longer, so they do tend to be around a full minute in duration, but they also have a very obvious peak to them, which is usually around that halfway mark, around that 30-second mark. So as a doula, that's a really helpful indicator to know that, you know, that client is going to reach the peak, the most intense part of that contraction about halfway through, so we can really support her to that peak and then remind her that that contraction is going to start to fade away. It's going to be less intense. She can stretch her breath out. She can start to relax and allow her body just to relax as that contraction leaves. Certainly another thing that you will notice, and you can really you can see such a difference as people move through, you know, into this more active phase of labor, is that when she does experience a contraction, it really takes her full attention. She can feel the buildup in the uterus. She can feel that tightening and intensifying, and most women kind of really intuitively go into their own little bubble, their own world. They'll often adopt a position, a stance, you know, even a repetitive series of movements, even vocalizations. Everybody finds their own kind of you know, coping mechanism, if you like, to really help them get through these, you know, intensive, you know, increasingly intense contractions. So when you notice that, I think, you know, as doulas, if it's clear that your client has found some combination of movement and behavior that is really helping her to sort of push through that intensity, we just leave her. We don't interrupt. We don't make suggestions. We don't pull her out of that you know, intense kind of labor land bubble that she's in. We just sit quietly in support. If she reaches out to us, of course we come in, we support, we say, how can I help? We offer suggestions. But if she's coping well, we just want to leave her and let her do what her body knows to do and what she's instinctively doing as far as coping. In terms of the cervix, again, you know, without getting too kind of obsessed about the how many centimeters, typically during active labor, of course, we do see more dilation, sort of that 6 to 8 centimeter mark, and we also see a significant thinning and stretching of the cervix. So it shortens, it thins, it stretches out, it moves further back as the baby comes forward as well. And sometimes you know, women also are aware that the baby feels lower. Even the register of the vocalizations they make tends to lower as well, so the noises go from being a bit more high pitched and sort of waily to sort of more groany and moany and that sort of noise. It doesn't mean that baby's going to come, you know, and be born imminently. Sometimes partners get a little freaked out when they start to hear the noises, but there's still time. So, but what I would say is, again, depending on your circumstances, if you're supporting a client at home and you start to observe these things, these contractions, which are really consistently coming 3 to 4 minutes apart, lasting a good long minute, mum's going into her own bubble, you know, the vocalizations are kind of lowering, and she's starting to feel that a little bit more pressure, particularly around her bum. That is a wonderful sign that labor has progressed and is progressing really beautifully. If she is birthing in the hospital, that's when, again, if you are with them or with your client, absolutely suggest now's the time to, you know, get in the car and go. You know, if you are on the phone and you're, you know, you had made plans to meet your client at the hospital, that's when, you know, if you're listening to her on the phone, you know, you would advise, look, I think now's the time to hop in the car and get to hospital, and I'll meet you there. You know, often people are nervous. Again, if it's a first baby, they're not sure. They often, to be honest, they tend to go into hospital too early rather than too late. But one thing that they can do is always call ahead, and they should call ahead really, to Birth Suite and speak to a midwife on the phone. And often that midwife will give some, some good advice, just listening to her on the phone and how she breathes and how she is able to talk or not talk during a contraction. They're pretty skilled in assessing, even over the phone, where a client or where your client may or may not be in labor. So they're not always right, I should say. They're not always right. And sometimes they can actually be a bit dismissive of first-time mums who think that they're further along, and they kind of go, oh, you're probably still really in early labor. It's happened a few times where that woman is really known she's a lot further along, and she's gone in anyway, despite the hospital saying, no, I think you should stay at home a few more hours, give us a call later or in the morning. So, I think the one thing in that situation we always want to remind clients is listen to your instinct, listen to your gut. You may not have had a baby before, but you know your body better than anybody else, and you've certainly grown your baby, so you know your baby better than anybody else. So if there is any of those concerns, then absolutely they should listen to their gut and to hop in the car. And look, if it is too early, they'll be reassured, they'll check baby out, and they'll be sent home, which is not the end of the world. So that's active labor. And we'll move on now to the final phase of stage 1. So this is, as I said, the final phase of the first stage of labor. It is more commonly known as transition. It's a good name because it really does describe what is happening. The body is transitioning from stage 1 to stage 2 of labor, which is the pushing stage, which we'll look at shortly. A lot of pretty negative things get said about transition, and to be fair, it is for most people, without doubt, it's the most intense part of the labor. It's the point at which the cervix is completing its dilation, and babies are moving down, and they're moving often quite rapidly. So there is a lot of physical intensity, there's a lot of hormonal intensity, and emotions as well. So everything is kind of, all happening at once, and it can feel very, very overwhelming for the birthing person to be experiencing all of that. It's physically tough, it's emotionally tough, etc. The good news about transition is that it is the shortest part of labor. For some people, it is really just a few contractions as they move through into this next stage of labor. And for others, it's a little bit more prolonged, and it can, in some cases, last maybe up to about an hour, but that would be quite unusual. I think more commonly we look at sort of between 10 and 30 minutes of transition as being kind of a bit more normal, more average. The contractions themselves are very intense. They're as close together as they will get at any stage of labor. So they can be 2 to 3 minutes apart. Look, honestly, they can be as close as sort of 90 seconds apart as well. They're also very long, so they're lasting a minimum of a minute, but often they're about a minute and a half long. So if you can think about it, they'd be a minute and a half long, you'd have a minute and a half break, and then you'd have another one straight on top of it. Transition contractions as well can kind of have these sort of nasty, almost like a double head, if you can imagine this pattern, rather than it reaching a peak and then coming down, nice and evenly on the other side. These ones often with transition, they come up. Just show you here in my hand. So they kind of reach that peak, they start to go down, and then you get another peak, and then it might start to fade away. So, mum's only just starting to kind of get her breath back, and then it intensifies all over again, and it's like another contraction. It's a bit like waves breaking on top of each other. That's kind of how it feels, and so hence why it can often feel very overwhelming. So, your support at this stage of labor is so important. It may be also that your client has a partner with her, or a close family member or a friend. It doesn't you know, look, it doesn't really matter who provides this, you know, really intense support, but the fact is that people need it during transition, because it's usually the point at which people really start to feel like they're kind of coming undone a little bit and that they can't cope anymore. If people have avoided or managed to avoid pain medication until this point, this is when they're going to start yelling for the drugs, or saying kind of sort of slightly odd, irrational things like, you know, I can't do this anymore. I don't want to have my baby today. I'm going to go home. I'm going to come back tomorrow. You know, things like that. You know, other things as well. So some of the sort of physical side effects, if you like, of transition that are all very, very normal, other than the sort of, you know, that sense of overwhelm. Things like shaking, so physical shaking of the body, sweating profusely or shivering, sort of one extreme or the other. Vomiting is a really common one as well. You know, sometimes it's really out of the blue and it's really quite intense vomiting. Again, midwives, if you look at their behavior, you'll see that this doesn't bother them at all. In fact, from their perspective, it's actually quite a positive sign, because they know that this is transition, which means they know that baby's going to be, you know, not far behind. So as a doula, we want to be really at this point in labor very calming, very reassuring, lots of soft, gentle words of encouragement. And, you know, it might mean holding, you know, the vomit bag there. It might mean, you know, just making really intense, sustained eye contact. A lot of women in transition don't want a lot of physical touch and holding, so be mindful of that she may not want massages or counter pressure or anything that was very helpful a bit earlier in labor. She might just want that physical connection with you, just the eye contact, as I said, those really, you know, loving and caring words. And again, they can come from you, they could come from a partner, they could come from her mum. Doesn't matter. It's just that she needs to know that she is supported throughout, and that support is physically close by to her, that she can really make that eye contact and see that you're close by. You know, reminding her that she's going to meet her baby really soon and that she's doing an amazing job. All those sort of things. Don't underestimate how powerful and how positive they may be for her. So that's transition. As I said, it is intense, but bear in mind, as I said, it is the shortest part of labor. Some people it's almost seamless. They kind of go from, you know, active labor, what kind of seems like transition, but then they say, oh, I feel like I need to push. So, you know, there's a real variation in there. And, you know, some people, as I said, move right through. Others, they have a sort of prolonged period of transition. So everyone's a little bit different. There is actually a really good resource. I'll be sure to actually add it to your sort of resources and things that you can, you know, have on hand. Penny Simpkin, who is somebody we've spent a little bit of time kind of looking at. She was in that video in the very first session. She's one of the founding members of Donor. And Penny has a really great resource called the Take Charge Routine. So I'll stick that up there so you can access that in Better Impact. It's a really, you know, logical and very helpful little strategy, if you like, to help people kind of come back down when they're sort of really struggling through transition. So it's a great doula tool. It's a great tool for partners to teach to partners as well. So have a look out for that, the Take Charge Routine. So we're going to move on now to stage 2. So now we are moving on to stage 2 of labor. Remember the 3 stages, so this is the second stage, and more commonly known as the pushing stage of labor. Following transition, as I said, for some people it's quite a sort of seamless transition to pushing. For others it's a sort of a longer period until they start to feel sort of this sort of undeniable urge. The length of time that this stage of labor can last really varies. you know, from, you know, a few minutes, which wouldn't be super common, again, particularly with a first baby. But you know, anywhere I would say from sort of 1 to 3 hours is kind of that normal, if you like, normal range. It can take longer, and I think something for to share with clients is that newer research has really shown that we should not be putting an absolute deadline or time limitation on the pushing stage, as in, you know, oh well, you've been pushing for 3 hours now and therefore it's no longer safe to continue pushing. We're going to need to use instruments to help get this baby out, or, you know, even potentially a very late cesarean section. The bottom line is if the mother and the baby are coping well with this stage of labor, that we, as I said, we should not be imposing strict time limitations on labor. Interestingly, the contractions change again during this stage of labor. As you remember, in transition, they're kind of really close together and kind of on top of each other, a bit like the sort of that analogy I gave of waves breaking one on top of the other. During pushing, the contractions actually space out again. They're more like that sort of active labor phase, sort of 3 to 5 minutes apart. They last quite a long time. Again, they might be 60 to 90 seconds in length. But interestingly, they don't have the intense peak to them that contractions in really intense active labor or transition have. There's still an intensity to them, but they tend to be the peaks of those contractions, and interestingly as well during pushing, again similar to that sort of double kind of peak in transition. During pushing you can have 2, even 3 peaks, but the peaks are actually urges to push, so an urge to bear down, and that intensity which is really instinctively causing the mum to sort of go, you know, and to push. So, you know, it's intense, but it's intense in a different way. And, you know, from a hormonal level, what's really interesting is that this is the one point in labor where we actually do see and want to see the presence of adrenaline. But this time adrenaline is not fight or flight, fear response adrenaline. It's energy adrenaline. It's the same kind of adrenaline surge that athletes get when they're exhausted, but they can see the finishing line and they get a second wind at the last moment. So that's exactly what's happening to a laboring person as well. They recognize that birth is imminent. You actually, if you kind of really are observant, you can see the difference between a woman in transition where she's kind of really spaced out. So, I mean, literally some women even like eyes are rolling back because they're so in this kind of in this other world. But when they get to pushing, it's like they're alert, right? They're really alert. They're really switched on. They're really present in the room again. And you can see this focus, this deep, deep focus. And that's adrenaline. That's exactly what's happening. It's the, you know, wake up, mum, pay attention, you know, got to give it your all now. And in most cases, women will feel a strong, really undeniably strong urge to start bearing down and to actively push. There is some really good information, you know, about pushing, and in fact, there's some information in the student workbook, which you'll see straight after the simple story of birth. You can carry on reading to the end of that page. But a couple of things that are important to sort of be mindful about pushing, and this is information that's important to share with your clients as well. What we want people to avoid during pushing is what we call directed pushing. That's when you think about movies and TV where you see women who take deep breaths and they tuck their chin, you know, to their chest, and then, you know, people around them, the nurses and so forth, and the doctors are going, push, 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 keep going, keep pushing, going, or they're counting 1, 2, 3, 4, you know, like that sort of thing. It's just, you know, cacophony of noise, and certainly not a peaceful kind of, you know, phase of the labor. That's what we call directed pushing. She's being directed in how to push and taught how to push. If a woman has full sensation in her body, i.e. she does not have an epidural and she can feel what's going on, we don't need to tell her how to push. Her body knows how to push. Pushing, the urge to bear down and to push, is a reflex. So it's no different to blinking or sneezing. It's uncontrollable. You can't stop it even if you wanted to. And so we want to encourage women to work with their body, push when they have an urge to push. That might involve short periods of holding her breath. But then she's got to make sure she takes the breath in between, and she's, making sure that that oxygen flow is continuing. Again, if she is doing a lot of excessive breath holding, number one, it's exhausting. Number two, it's not sustainable. Certainly not sustainable for 2 or 3 hours if that's how long she might need to push her baby out. So maternal exhaustion at that point of labor can absolutely cause fetal distress because the baby's own oxygen levels are compromised at this really crucial point when she needs to be breathing. She needs to be physically in a position where she's got all the benefits of gravity and good pelvic mobility, so upright, forward leaning positions, leaning over the bed on her knees, standing, squatting, using something like the Cub, which is an inflatable sort of birth stool, which I'm going to bring in to show everybody at our active labour workshop. Mind you, not all hospitals have them, but increasingly, for example, at the Royal Women's in Melbourne, I know they've got several Cubs now, which is so positive to see. But there are many positions in which a woman can move into that is they're physically comfortable, they're beneficial in terms of they help the baby to move down, they allow for pelvic space and mobility, and for those ligaments to stretch to allow for as much pelvic opening as possible. And then again, we're being, reminding her, take a breath, and when there's no contraction, just to breathe normally, to relax, to have a sip of water perhaps. Maybe a lip balm if she's doing lots of focused breathing, her lips might be really dry. So these are things as doulas that we can continually remind our clients to be doing. When we discuss birth plans, she can perhaps articulate some of those things in the birth plan. Her desire not to be told how to push, to avoid directed pushing, to have encouragement, rather than instruction. Things like that, are really good to put in your birth preferences. So that's pushing. And so there's a bit more information about that, both you'll probably find in Preparing for Birth in that booklet, but also some information in the student workbook as well. So finally, we reach stage 3. Of birth, the final stage, which is the delivery of the placenta. And as you can see on the slide, we have a picture of a lovely, beautiful, very juicy looking placenta and umbilical cord. And a couple of things that I want to talk about that relate to the third stage of birth. And the first and the main one is really helping you to understand what happens in the hospital setting. The standard approach to managing and caring for women at this end stage of the labor, and birth is not over until the placenta has been safely delivered. So that's important to remember. The birth of the baby is not the end of labor. So what hospitals really have adopted is something called active management of third stage, and it's kind of self-explanatory. They are managing this part of the labor. What's involved in that is with consent, you would hope with consent, an injection usually of syntocinon is given. So that's a synthetic hormone, synthetic version of oxytocin, is given in the mum's thigh, either as baby is being born or essentially pretty much immediately following the birth of the baby. Different providers have got slightly different practices, as to exactly when they think is optimal to administer the syntocinon injection. It's given for 2 reasons. The first is it does tend to hasten the delivery of the placenta. It encourages the uterus to keep contracting efficiently after the baby has been born, so that the placenta will start to come away from the lining of the uterus, and to come away so that it can be expelled quite efficiently. With SINT, you could expect the placenta to come out within anywhere from sort of 15 to 30 minutes following the baby, but and definitely within an hour. The other reason that it's given, and there is actually some quite good evidence to support this, is that it does quite significantly reduce the risk of a postpartum hemorrhage. There is a really interesting article, and again, as I'm talking and I'm thinking, I will post a link to it so you can have a read of it on Better Impact. It's actually another article by Dr. Rachel Reed, that fantastic professor of midwifery who's behind the Midwives Cauldron podcast. She wrote a really, really good blog about active management, and for somebody who is so passionate about a physiological labor and birth, even when Dr. Reed actually advises that active management is beneficial and probably the safer option for women birthing in a hospital, that there's probably some really good science behind that. And the reason that she does suggest that it's probably the safer option to consider is because the reality of birthing in the hospital system is that people are birthing with an awful lot of intervention. And if you recall from our very first session in person, the induction of labor rate is now rapidly approaching 50%, which is insane in itself. But when you induce labor, you are already radically altering the hormonal sort of flow of labor, and you are almost undoubtedly going to be introducing a cascade of intervention that will follow. We augment labor, meaning we speed labor up artificially with synthetic oxytocin, with syntocinon. We break waters. We do all sorts of things to people in labor, and resulting in as far from a normal and physiological flow of labor as possible. And the truth is that the more we intervene with labor, the higher the risk there is for a hemorrhage after birth. The other thing as well is that sometimes, and again, particularly we see this with an induction of labor, is a very long labor, a labor in which a woman's uterus is contracting probably far longer than it ever normally would in a physiological labor and birth. And so we have a very, very tired uterus that is not going to clamp down efficiently following the birth of the baby, and therefore putting mum at higher risk of excessive bleeding after the birth. So all that said, the truth is that for women who've had a pretty normal, I say normal, but we know that there might be socially normal, but hormonally is very abnormal labor, an active management of third stage is probably the safest approach to take. So it's that injection of SINT, as I said, in the thigh. If she has an infusion of synthetic oxytocin via IV, she'll also require this in addition. So it's not like, oh, well, she's already got the IV, she doesn't need the injection. She would need both. The other thing that's really important to be mindful of when we're talking about the third stage of labor is the whole discussion around cord clamping. So as you can see in the photo, we've got the umbilical cord there. Now, when a baby is born, immediately following birth, in their body at the time of birth is about 2/3 of their total blood volume. So the total amount of blood that baby will receive eventually, about 2/3 is in their body at birth, which means about 1/3 of that blood is still either traveling in that umbilical cord, making its way to baby, or it's still in the placenta. And people call it cord blood, placental blood. Let's be honest, it's baby's blood, right? It's really, really important that the baby get that blood. And so the way to ensure that they get as much blood in their body as possible is what we call either delayed cord clamping, or I think a better name for it is optimal cord clamping. And what that basically means is that it's an instruction that your client will pass on to her care provider. Again, it's a really good one to add to the birth preferences, is to delay clamping and then subsequently cutting that cord until that cord has stopped pulsating. There's clearly no blood flowing through it anymore. The cord becomes quite limp and quite sort of, grayish, pale. It's lost that sort of thick, quality to it, which you see immediately following the birth of the baby. It really changes, and you can visually see that quite clearly over the sort of course of the first sort of 5-6 minutes or so, even after the birth. So that's optimal cord clamping. And what's really incredible is that when we do that, when we do wait for the cord to stop pulsating and for all that blood to travel through to baby, ultimately they will end up with somewhere between about 95 and 97% of their total blood volume. And they've done studies on babies even 6 months after birth, which have shown that those babies who had optimal cord clamping still had significantly high levels of iron in their system at 6 months after birth compared to babies who had immediate cord clamping. And there are huge benefits, for having those greater iron stores. They are less likely to experience, those sort of early infant infections. The other incredible thing really about this particular source of blood that baby receives is that it has the highest concentration of stem cells that we receive in our entire lifetime. And so, that blood going to baby is really, think of it as like the building blocks of their lifetime health, immunity. They're getting all the immune responses from infections and things that mum has experienced in her, in her life as well. So, it's an incredible gift to pass on to the baby. One thing that, particularly with your clients through Birth for Humankind, in almost all cases, your clients will be birthing through the public system. And interestingly, the public system, and even as far as RANZCOG, which is the Royal Australian New Zealand College of Obstetricians and Gynecologists, they have a fairly, consensus agreement and statement which does not support the use of private cord blood banks. You do see them in the private hospitals and the private maternity hospitals. There's a lot of controversy around the benefits of private cord blood banking, but RANZCOG and the hospitals, the public hospitals, even the Royal Women's have got a statement up on their website if you look for it, which pretty categorically, sort of denies, that or states that there is really insufficient evidence to support the high cost, and long-term efficacy of storing your baby's own cord blood for an extended period of time. So really the evidence is very strong, it's very conclusive. The best place for that blood is in your baby's own body, and that's a message that we can share with our families, with our clients. Look, following the successful delivery of the placenta, the midwife, normally it's the midwife, will check the placenta very carefully and make sure all of it has come out. It's whole, the membranes, everything is there. It's really important that they check that carefully, because even a tiny amount of retained placenta can cause really severe infection and bleeding for mum, and would require a surgical removal of any retained placenta as well. So they do check that carefully. You might want to talk to your client and say, would you like to see your placenta? Would you like to keep your placenta? Would you like to encapsulate your placenta? There's all these sort of considerations. It's her placenta. It's up to her to decide what she would like to do with it. And if she's happy for it just to go, be treated as hospital waste, and she doesn't want to look at it either, that's completely fine as well. So once birth is officially over, baby's born, placenta is out, eventually cord is clamped and cut, and now mum and baby are technically separate, then what we want to really ensure and support is that extended skin to skin between mum and baby, which again really is, I do have to say, is something that is honoured, is supported, is encouraged, and really the only situations where perhaps there would be separation of mum and baby is if the baby is unwell, is not adjusting to sort of life earthside all that well or initially, and may need some pediatric assistance, some resus, for example. Sometimes those things can actually be done with the baby skin to skin with mum, and in fact, again, evidence is very supports that we don't separate mums and babies, and in fact babies are more likely to settle and to adjust outside of the womb, even if they do need some oxygen when they are skin to skin with mum. And there's actually, again, more evidence to support delayed or optimal cord clamping, because until you cut that cord, there is still oxygen that's traveling through that cord to baby, so they're getting a secondary source of oxygen. So for babies that are born very quickly, or are prem, or showing signs of really needing a little bit more time to adjust to life outside, we want to keep that cord intact for those babies in particular. All the other things that are done, which we'll talk about in more detail in a later session, the newborn tests, the procedures, the injections and weighing and measuring and all of that sort of stuff, is generally not done for at least an hour or two after the birth. And again, that's a really good thing. We just want mum and baby to be together, one unit basically, skin to skin, for as long as possible. So a lot of information I know that I have just shoved into these last few slides about labour. I hope it's been interesting and sort of helpful to understand things as we kind of do, take each section, apart. There's one more slide just sort of before we finish up a discussion of labour altogether, and that's to look at what happens with what we call a spontaneous rupture of membranes, or when your waters break naturally. So that's the final slide, and then we'll have kind of completed it to sort of look at labour. Okay, so as I said, we're going to just finish up by looking at what happens when your waters break, or when your client's water breaks. And the reason I kind of put this separate and actually at the end is because, and I do this in my classes as well, my childbirth classes, is I want people to move away from this really Hollywood TV idea that the way labour happens is woman's water breaks, there's this dramatic gush of fluid, and it's usually on the floor of a shopping centre or in a restaurant, and then everybody panics, and the husband becomes this sort of blubbering idiot, and and then they drive erratically while she's in full-blown labour, and then she gets into a wheelchair, then about 5 minutes later she has baby. So this is not what happens, and I'm sure you know this anyway. But it's important to just know that the majority of labours begin with contractions, and labour, particularly if labour is left just to progress very normally, then a woman's amniotic sac will rupture very normally at some point during labor. When is anyone's guess. It can happen early in labor, it can happen right at the end of the labor, sometimes it doesn't happen at all, and in rare situations a baby is actually born in the caul, C-A-U-L, which means that the baby's actually born with the sac intact around them, which is really extraordinary. And I honestly haven't managed to see an on-call birth yet. It's certainly one of the things I'm really hope one day to witness. Because it's very special to see a baby being born in the sac. You can actually, if you go onto YouTube, if you're kind of curious to see what an on-call, and that's a French term, E-N for on, in, meaning in, and then C-A-U-L, so in the sac essentially. If you go onto YouTube and you look up an on-call birth, you no doubt find some really beautiful births to look at. So as I said, majority of labours begin with contractions. Only a small percentage, about 17% will begin with a spontaneous rupture of membranes. you can see from the little illustration here as well that you know, the tear in the sac can actually be either what we call like a sort of a low tear or a low break in the sac, which means that because of the weight and the pressure of baby's head will cause a more dramatic and obvious gush of fluid to be released, and in those circumstances people are, you know, it's pretty obvious what's happened. But saying that, the tear in the sac can actually be quite high up, and because, you know, obviously at this stage, you know, you're all baby, there's not a huge amount of space around the baby and only little pockets of fluid here and there. So what happens is the baby kind of continues to wriggle around and move, because babies are moving all the way through labor. Is that what mum might experience is more of an intermittent drip, or, you know, a little bit of a trickle here and there, and it's kind of here and there. You know, she might lie down or sit down, gets up, there's a bit of a flow, and then it stops. And in those situations, sometimes women are a bit confused, and they're like, oh, have I honestly, have I wet my pants? Am I leaking urine? And that's why this little acronym here, which you can see on the slide, which is COAT, can be really helpful, again, to share with your clients. So C is color. If they think their water has broken, get them to be looking at and mindful of what is the color of this fluid. The best thing to do is actually to put in a sanitary pad or a maternity pad into their undies and to just monitor it, keep an eye on it. Amniotic fluid is essentially colorless. It may have a little bit of a light pinkish hue to it. It might have, you know, again, a little bit of blood, a little bit of, you know, those membranes. That's all normal, and that's fine. What we, you know, don't want to see ideally is what's called meconium. Meconium is the baby's first poo, essentially. It's not always a cause for concern, you know, especially if your client is full term. We'd expect a full term healthy baby to have a bowel full of poo, ready to be, you know, expelled soon after birth, and sometimes occasionally technically before birth. So it's not necessarily a cause for concern. Excuse me. But meconium can, in some cases, be an indicator that the baby is not happy. The baby obviously has no way of communicating with us other than through, you know, a slightly concerning fetal heart rate, which we can pick up through monitoring. But if mum is at home and there's no monitoring going on, if the baby releases their bowels in essentially in a stress sort of behavior, it's their way of saying, hey, I'm not happy in here. So it's a signal for us to be, you know, to be alert and to certainly not ignore. So we want to tell clients that if they notice any discoloration, and meconium, to be honest, will look kind of a bit like poo. It'll be browny, greeny. The fluid may be flecked. It may be thicker. It may be, you know, any of those sort of combinations, but it's not going to be clear or light pink, and there's a very clear, you know, sort of distinction there. So if mum notices any meconium, we want her to call the hospital and to go in, you know, as pretty soon, and to make sure that she's checked out. Even if she's not in labor with meconium, and if they confirm that it was meconium, then she won't be able to go home. They'll want to keep her there and monitor her pretty closely and make sure baby's okay. If her water breaks and it is clear, the hospital will certainly say they want you to come in. They will like your client to come in, and you know, what will typically happen if there's no contractions is they would just sort of assess baby, make sure baby is well, baby's moving, fetal heart rate is normal, and after a bit of monitoring, most likely they will send your client home. And that's a good thing. It might feel like a disappointment. She might feel like a real anticlimax, so she's got all worked up to go in, and then she gets sent home again. We want to remind clients that it's a good thing, that labor is far more likely to begin and to actually progress normally when she's at home in her own comfort and home environment. Some people will make a decision to stay at home if they can recognize that their waters have broken, they're clear, it's clear fluid, and they don't want to go in straight away. As doulas, it's not for us to advise one way or the other and say, oh no, you should definitely stay at home. We can't do that. That is essentially giving medical advice, which obviously we can't do. So I think what we do want to tell clients to do is let them know that they probably should call ahead to the hospital, let them know, update them, and then it's entirely up to them. If they choose to stay at home for a period of time, hoping that contractions will start up by themselves before they go in, or they may choose to go in pretty quickly straight after sort of spontaneous rupture of membranes. So we want to support their choice without telling them what to do. The next letter here in the acronym is ODA. So for women who have sort of a bit of a trickle, so not that very obvious gush of fluid, but a little bit of a trickle, and she's not sure, oh, is this urine, is this amniotic fluid? Might sound a little bit kind of, a bit too much, a bit gross, but smelling it, especially if she's got a pad in, have a little bit of a smell. We all know what urine smells like. Amniotic fluid is essentially quite odorless. This might sound a bit strange, but to be honest, sometimes amniotic fluid smells a little bit like semen, but it doesn't smell like urine, and that's the important sort of thing to sort of differentiate the two. So if she's not quite sure, that's one thing that she can do if she wants to. Keeping a pad in is really helpful, and not throwing it out before she goes to hospital. Take it with her, even if she's changed pads. Take one, put it in a Ziploc bag and bring it to the hospital, because the hospital, the midwives can check and test for amniotic fluid based on the pad. And also they just want to have a look at it and make sure that fluid really is clear. The A is amount. So it's the volume, was it the big gush of fluid, or was it the sort of more, perhaps a tear higher up in the sac, which has resulted in a bit more of a trickle. And then finally, T for time. And that is just noting the time of day or night that she noticed it the first time. She can jot it down on her phone or on a piece of paper. And the only reason for that there's any importance or significance to that is because after an extended period of time, and by that I'm talking usually in excess of 24 hours, there's a very small but slightly increased risk of infection setting in. If you think about the sac, it's essentially a kind of a barrier between the baby and the outside world, and when that barrier is removed and that baby is then exposed to bacteria which may set in through the vagina and into the womb. So it's a very, very small risk, and the reality is that most people are pretty immune to the bacteria in their own home. The same cannot be said about bacteria in a hospital setting. There's some pretty nasty bugs in the hospital. And so there is actually a lot of really good common sense to staying home as long as possible and waiting for contractions to start and for labor to really establish. So just, remembering, just because your waters break does not mean you're in labor. Without contractions, it's not labor yet. Most people will go into spontaneous labor following a rupture of membranes, and that could be within minutes, hours, or a day or two. So there's a big variation of normal there. In most cases, particularly in the public hospital system, they're not going to be rushing to, move labor along, particularly if the membranes are clear, there's no meconium. They want to give mum an opportunity for her body to go into labor by itself. So she gets sent home. Usually they'll say, give us a call the next day, the next morning, or if it's morning when she comes in, give us a call tonight, and give it a good 12 to 24 hours before there's sort of any discussion of next steps. Occasionally women don't go into labor, or there's an extended period where the hospital's starting to get a little concerned about the amount of time that's passed, which is called a prolonged rupture of membranes. As I said, usually it's 24 hours or more. Prior to a serious discussion around induction, the first discussion which might occur is to get mum to consider the use of intravenous antibiotics. And again, it's her choice to accept, to decline those, but often it will buy her a bit more time, maybe another 12 hours or so minimum, in which case she may be able to sort of need that to sort of really get into established labor. So again, these are really helpful things to know, that this is kind of the sequence of events that are likely to happen should this be how your client's labor begins, and what the hospital response may be to her, and the choices and the options that she's got to consider. So again, with a lot of information, I know that I'm kind of like throwing at you with these slides, and there isn't the opportunity for you to ask questions. So please make sure that as you're going through these, if you've got questions or there's things that you want to talk about, jot them down so that we can go through them in the live check-in online, which we do, as you know, every couple of weeks or so. So that way, you're not going to forget about things that you'd like to bring up and ask questions about. So that's what happens when your water breaks. So here we've got just a few questions, and it's just one of the sort of small little assignments, I guess, for this week. So based on everything that you've just listened to about the various stages and phases of labor, here's some questions that you can sort of jot down some thoughts. So when should your client call you think? When should you go to her? When would you go to the hospital? And a scenario whereby your client calls you to tell you that her waters are broken, and what do you tell her? Okay, so you can jot them down as just a small little assignment here. So this slide just sort of gives a kind of a broad overview of our role as doulas, like throughout that perinatal period. So really throughout the pregnancy, and of course labor and birth, and into early postpartum. But in terms of when you first have an encounter with your client, really varies. It varies with Birth for Humankind. It'll vary with your private clients. Some people hire doulas really early on, pretty much, the sort of joke, the pea on the stick, and they know they're pregnant, and they start seeking doula support. I would say probably more commonly people are thinking more seriously about support in, once they've hit or gone beyond that sort of 20-week mark, and they know all is well with the pregnancy, and they're sort of starting to think about their preferences and thoughts around support. So sort of that early second trimester is when typically as a privately practicing doula you'll probably get more inquiries. With Birth for Humankind, again, it really varies. Some people are, connected with their doula, their volunteer doula, quite early on, and other people it's very last minute as well. So it's kind of everything in between there. I guess your role varies depending on when you do meet with your client. If you, have a client from quite early on in pregnancy, there's some great advantages to that. Obviously, it's you have the opportunity to build a really lasting and meaningful relationship, and one that's really based on trust and that continuity of care which you get to provide. But often, because it's earlier pregnancy, she may be very well seeking information, resources, clarification, information on her pregnancy testing, prenatal testing options, and things like that. So, it sort of speaks to that point I made earlier about it's really helpful for us as doulas to know where to access good quality, as I said, evidence-based and current information. It's, again, to reiterate, it's never our role to make medical decisions or make choices or decisions for our clients. But, when they are seeking information, we want to be able, at our fingertips, to be able to quickly forward information that's relevant, that's also user-friendly. As I said, we don't want to be sending her, abstracts and research papers. We want to send clear information about what does this mean for her, and how that's going to help her to make decisions or have important conversations with her care provider. So we will, as I said, in a future session, really look at and explore where do you actually find these really good sources of evidence-based information. So in next week's session, we will be looking more at sort of, antenatal appointments and, in more detail about, when you'd go to your client, when you would meet them, those things. But I just thought to sort of preface that and maybe just sort of give us a little bit of an overview prior to next week's session, just to give you a sort of a broad understanding of what that looks like. Okay, so in early labor, we would expect that you'd have quite a lot of contact with your client, either phone conversations, texting, for example. Again, we mentioned, for those of you who were able to join us for the live check-in yesterday, actually, which is when I'm recording this, that Birth for Humankind frequently uses TIS for interpreter services, and so you may, depending on who your client is and her level of English, you may need to utilize an interpreter as well. These early phone support conversations. If you are talking about a private doula client that has hired you, again, there's very much your preferences and decisions as a private doula and your agreement with your clients, but many doulas do provide home support in early labor, and thereby helping clients potentially to stay at home longer. With Birth for Humankind clients, it varies. So a risk assessment will be completed by your doula supervisor, so with Kath and Christine, letting you know ahead of time that the home is a safe place to visit for antenatal appointments and potentially for early labor support. Otherwise, your visits will take place in a variety of places, including, a local cafe, for example, in the community in some space, or at the hospital itself. Okay, so it's just a little bit of an overview of sort of early labor and the sort of communication you'd expect to have with your client. So as your client moves, out of that early stage of labor and really into active labor, this is really ideally when we would expect, that you would be with your client, continuously from this point on until the baby is born. And then typically you would remain with your client for a couple of hours after the birth. You may be both of you staying in birth suite that whole time with baby. Again, COVID has been, thrown up all sorts of complications as far as how long doulas can stay and what happens after mum leaves birth suite. I think things are easing, and certainly I think by the time you've completed your training and your induction and everything, by the time you're actually supporting clients, hopefully we'll be largely behind all of this, and so you may find following the birth of the baby that there's no issues with you accompanying your client to the postnatal unit and helping to settle her and baby in there before you actually leave the hospital altogether. If you have a client that either needs an elective cesarean or there is an emergency cesarean, then depending on circumstances, you may also be able to accompany her in the operating theatre. If you're the only support person for your client, then you will be. If there is another person that she has with her, such as a partner or a close family member that she would prefer is there for the cesarean, then hospitals will typically only allow one person in the theatre. But saying that, following the surgery, you may be able to get permission to support your client in recovery while the family's in the sort of family waiting area, or if the dad is their partner, they may be in postnatal, maybe with a baby. So we'll talk more about, we've got a sort of session really where we really kind of unpack and explore cesarean section, but you may be with your client either in surgery or soon after in recovery. And really your role, you know, in the most simple and fundamental terms, from active labor through to the birth and beyond, is to provide that continuous emotional and informational support throughout. And again, if there are other people present, other support people, then we know we're all working as a team to provide that continuous support for your client. I think one of the really wonderful things about doula support, and we've touched on this already a few times in the course, is the fact that, you know, doulas are unique in that they can provide this continuity of care, which is so lacking in our current maternity system. You can see from the slide, that first point there, most women experience what we call stranger care during her pregnancy, the labor and the birth, meaning that she doesn't know who she's going to see. She sees a different provider at every appointment. She doesn't know who's going to be there when she's actually in labor. And of course, you know, most labors go beyond, you know, a single shift. And so she's likely to meet, you know, 2, 3, even 4 different midwives throughout the course of the labor. And so you play a really important role in providing that, you know, as I said, that continuity of care. You know, if you've got the opportunity to meet your client quite early in her pregnancy, you've had often a few months to really get to know each other and for her to sort of really build that lovely relationship of trust with you. But, you know, there is always the, I guess, the danger of, you know, those boundaries being crossed a little bit, you know, and this is the point we've got here at the very bottom of the slide. While it's important to be mindful of boundaries, the relationship of trust you build with your client is very important. And sometimes you feel like you're walking a little bit of an invisible line there. You know, when is it, when are you providing support, and when is this becoming perhaps a little bit of a relationship where she's relying on you, or that you're feeling that there's a little bit too much pressure on you to kind of provide everything, and you're feeling a little bit stressed about that. So again, we'll talk a bit more about you know, boundaries, you know, throughout the course actually. But you know, there's no doubt that our role is quite unique. You know, we're not medical care providers. We're not a person that represents a person in a position of authority. And thinking very much with a sort of a birth for humankind hat on, you know, it's important to remember that many of the women that you'll support have got trauma histories, have had really stressful and traumatic experiences with people that they perceive to be in positions of authority. And so you have this really unique neutral territory where you lie as a doula. And you do have the opportunity to build this sort of sustained relationship with her. So trust is a very, very big thing. And I would say it's sort of tenfold important when we're considering the kind of women that we support through Birth for Humankind. Okay. So we will, you know, sort of next week start to sort of really explore, you know, things like birth plans, birth preferences, and the sort of the conversation that happens before that is to sort of really establish your client's goals for their own birth, but also expectations of their support, the support that you provide them. you know, as you get to know your client, as she gets to share with you, you know, her own, you know, as I said, her own goals for the birth, you know, you may find yourself thinking, you know, internally, I would never make that decision. Like, I would never choose to do that. Or why would she do that? You know, you can see in the first point there in the italics, not my birth, not my baby. You know, almost think of that as your little mantra. I promise you, it's something you'll repeat to yourself again and again and again. Not my birth, not my baby. Because sometimes your clients will make choices in, you know, good informed decisions about their own care that really contradict what you might do if you were in the same situation. So it's not for us to make you know, for us to establish your clients' goals, they've got to establish their own goals, and you know, you both of you need to set those clear boundaries and establish, you know, what the expectations are. You know, we can certainly assist her to write a birth plan, but I would really sort of put a caveat around that and say it's not our job as the doula to write her birth plan. Give her the tools, give her the information, share some templates even, and then through your discussions, help her to arrive at her own preferences. That's really important. Or to sit, if she has a partner, for the two of them to sit down together and work on that. And you can provide feedback and all of those things, but we don't write the birth plan. Make sure that from the outset you really clearly articulate what you do and what you don't do, and therefore she will have a very clear understanding and a realistic expectation of the support that you can provide. If there will be other people at the birth, for example, a partner, great to have them at the antenatal appointments. Really important to build that relationship of trust with them as well. But there may be other people that you're not going to meet maybe till the birth. It might be a friend that comes along. It might be a relative, a sister, a mum, etc. So you're not going to get maybe the opportunity to meet ahead of time. But in the absence of perhaps meeting other people that will be there actually at the birth, or very likely to be at the birth, then you should certainly discuss in the antenatal appointments with your client. So, okay, so your mum is hoping to be there, or your best friend is hoping to be there. Of course, I will be there. What do you see your friend, you know, supporting you with, or what would you like her to help you with, or, you know, and help to define those different roles, you know, and she may not know, or be able to sort of, clearly envision that, but it's a really helpful conversation to have, you know, and get her thinking that, and I'm thinking quite early on, that different people can actually provide different forms of support. You know, what a partner can do versus what you as the doula can do are very different. You have a very different relationship with her, and sometimes that's a good thing and sometimes it's not such a good thing. As you will experience when you are supporting women through birth, if a partner is present as well. So these are just, as I said, important discussions to have early on, and make sure that everybody's on the same page. This is an acronym some of you might have come across before, the BRAIN. As you can see from the slide here, BRAIN is an acronym. It is a really, really fantastic tool to help your clients with their informed decision making, which obviously then leads to giving informed consent or informed refusal for any treatment, any intervention, anything really that can really affect their labor. So one of the things I do with clients, and also with in childbirth classes, is I give every client their own BRAIN card. It's a little kind of credit card sized card. You could make your own, and I say, if they have a partner, I say, pop this in your wallet today. You'll forget it's there, but it's there when you need it on the day. Excuse me, again, because as doulas, we're not making decisions for clients. We need them to be able to step up and to advocate for themselves as well, and to clearly communicate their choices and their preferences. But the way that they arrive there is about, as I said, it's informed decision making. You can't make a decision. You can't say yes or no to something if you don't have all the information. And that's what the brain is designed to do, is to help extract that really important information from care providers. So you can apply any scenario, any intervention you like. And in fact, that's one of the homework exercises I'm going to get you guys to do, is to pick an intervention, pick a really common one. It might be an artificial rupture of membranes. It might be an induction of labor. It could be anything. So I want you to sort of pick your intervention and then sort of systematically go through it. So what would be the benefits of artificial rupture of membranes, right? And then very importantly, what are the risks of that? And if you can see, carefully in the sort of smaller type next to each of these are some very, very important questions to consider. So under risks, for example, not just the risks to consider, but what other procedures may follow this? And that's one of the really crucial things to understand about labor intervention, is that interventions don't exist in and of themselves. It's like, oh, here's one intervention, we've done that, let's carry on with labor. In almost all circumstances, one intervention either requires other interventions happen, and I'll give you an example of syntocinon, right? The synthetic form of oxytocin requires continuous fetal monitoring, okay? It also means immersion in water is now no longer an option. She can't have the water birth anymore, and she probably won't even be able to use the shower. Okay, so those are the things that that follow saying yes and consenting to syntocinon, for example. You've got A for alternatives. What other things could she explore first as an option before perhaps saying yes to, what has been suggested? I stands for intuition or instinct. So what is her gut telling her? Also maybe talk to the partner. How are they feeling about things? But first and foremost, primarily, it's about the mother's intuition about her own body. And the N on this card has N for nothing, but the card I give clients has N for nothing, not now, or no. So it can be for all those things, right? And doing nothing is an option. It's as much an option as doing something. And so again, it's important to let clients know that they have the right to decline and to say thank you, but no thank you. Okay, so the brain is a really, really great tool, as I said, to really help clients to come to, making decisions about what they feel is the right thing for them to do. I definitely encourage you to make your own brain card. If anybody's a bit of a sort of design whiz, there's programs like Canva which you can use. We'll look at sort of when we get to the end of the course, the sort of the business of being a doula, we'll explore some of those really handy tools to help you design business materials, marketing materials. But Canva, CANVA.com, is a free website. It's a really brilliant tool to design things like this that you might hand out to clients as well. Okay, so that's your brain card. Okay, so we've almost come to the end of week 5, and I'm going to finish up with, again, just introducing a small activity, a sort of assignment for you to do, and that is to sort of carry on from what we've just looked at with the brain card, is to think a little bit more about informed decision making. And I've put here 3 sort of different scenarios, all, to be honest, pretty common, certainly not unusual scenarios that can occur. And I guess what I'd like you to do is to read those scenarios and then to jot down, it can be dot points, you don't need to write a huge amount. Dot points is fine about, how you would then react, what you would do as the doula. So we've got here the first one. Your client has had a long early labor. She's now fully dilated and has been pushing for 2 hours. She's exhausted and discouraged. The doctor comes in and suggests a cesarean. What do you say to your client? Okay. Second one, your client has been assigned to a midwife that doesn't seem to value her opinions or respect her choices about her labor. You can see that she's clearly upset about being cared for by this person. What can you do as her doula? And the third one here says, your client is 6 days past her due date and the hospital is pushing induction. Your client is unsure about what this means and doesn't know what to do. What do you tell her? Okay, so with all the things that we've kind of discussed today and some of those extra resources you've got available to you, jot down, again, thinking from a doula's perspective, what would you say, what would you do, etc. So that concludes pretty much the sort of the content. The last thing I'm going to leave you with is you're going to be able to watch a video. It's on the final slide, or it actually probably might be uploaded separately into Better Impact. It's just a very brief little video introducing the Cochrane database, which I mentioned at the beginning of this presentation. So you kind of know a little bit about the history of Cochrane, what it is, how, what gets to be in Cochrane, and the quality of the study. And by all means, have a look yourself. Go onto the Cochrane website, have a play around, have a look. There's a very big section within Cochrane on pregnancy and birth, and just sort of see what you can look at without, obviously a lot's behind, as I said, institutional access and a firewall, but there is plenty of information that anybody can access. So if you're kind of curious to sort of explore Cochrane a little bit, then I'd really encourage you just to go onto the website and have a look yourself. So I hope this has been interesting. I know it's a lot of information. It's a lot to shove into a single session. Please, as I said before, jot down any questions you've got, anything you'd like to discuss further, which we'll do at the next live check-in. So look forward to seeing you all online soon.
Cochrane is all about making good healthcare decisions. Researchers all over the world can compare and compile studies that then become available for everyone through the Cochrane Library for healthcare professionals, patients, and policymakers. Cochrane produces high-quality literature reviews using systematic methods, which are called systematic reviews.
Cochrane is an international network of researchers that perform systematic reviews of the evidence. And the overall objective is to ensure that the treatment we use every day in the clinics are based on the best possible knowledge, which is independently assessed and quality checked.
Cochrane is a not-for-profit organization and only collaborates with organizations that are free from commercial interests. This way, Cochrane wants to counterbalance the research made by the healthcare industry.
Most of the evidence we have is generated by pharmaceutical companies, if we're talking about pharmaceutical treatment, or by device manufacturers, if we're talking about medical devices. And of course, there is a conflict of interest because you're basically testing the product that you are later going to hopefully sell and make a considerable profit on. So it's important to have a set of eyes to look at that evidence from the outside and quality assess it and summarize it, because otherwise it can be used scrupulously for marketing purposes.
Cochrane was founded in 1993. Today, there are over 50,000 people from more than 130 countries collaborating. Cochrane systematic reviews are part of the Cochrane Library. The Cochrane Library is a collection of databases that contain different types of high-quality, independent evidence, such as systematic reviews and other information, to inform healthcare decision-making.
To me, Cochrane International is a fascinating mix of enthusiasm, engagement, involvement, but also structure.
With a history of just over 25 years, Cochrane has already had an impact worldwide. 80% of WHO guidelines use Cochrane reviews, and the Cochrane database of systematic reviews is the most referenced health journal on Wikipedia, followed by the New England Journal of Medicine and the Lancet. There are a number of examples of how Cochrane has both improved healthcare and saved money.